Hi everyone, my name is Yi. I'm your host for Occupational Medicine Pearls podcast. With the third entry into infectious agent series, I want to cover melioidosis. Melioidosis is caused by a bacteria called Pagodaria pseudomeli or pseudomelii. It is a gram-negative aerobic bacillus bacteria, a saprophyte of wet tropical soil and surface water. Saprophyte means that it can just stay on the environment and live on them. And it can be a tier 1 select agent for potential bioterrorism agent. So it's important when we are including or handling the sample, the labs need to know that you are suspecting melioidosis because of the risk of infection. Where does it happen? So in Australia, it is endemic to tropical northern Australia, temperature above 20 degree, top end of the Northern Territory, tropical Queensland, and Kimberley region. And it has a strongly associated with wet season, monsoon, and cyclones. Also endemic in Southeast Asia, in Vietnam and Thailand. How do they get to our body? Usually through skin, percutaneous inoculation, which is the most common, through skin abrasions when they are contacting contaminated soil or water. They can also be inhaled through aerosol from cyclone storms and high pressure spraying, ingestion or drinking contaminated water, which is less common. Incubation periods can take from 1 to 21 days, but the latency to develop symptom may take decades. It was mentioned as Vietnamese time bomb based on the veterans from the Vietnam War who develop infective symptom only when their health is getting worse or developing diabetes with immunosuppression. Host risk factors are important. Diabetes is the most important thing, and others include hazardous alcohol use, chronic kidney disease, chronic lung disease such as COPD and bronchiectasis, cancer, immunosuppression, age older than 45, and indigenous Australians in the endemic regions are important of host risk factor. Clinical features are starting with asymptomatic seroconversion to localized skin abscesses, severe pneumonia to septic shock with multi-organ abscesses. That seems quite a broad spectrum of presentation, so there is not much point in memorizing a particular features. Since we are talking about occupational health, what type of occupation are increased risk? Usually that is in the agricultural and rural workers such as farmers, sugarcane, banana, and cattle station workers in northern Australia. People go to that area for construction and earth moving, mining, and resources. These cohort could be quite mobile with their where they work, and they may be unfamiliar with the hazard in the environment. Military personnel or first aid or response aid response worker to relieve cyclones or any weather events. Indigenous community and remote area workers important. Aquaculture and fisheries, so they are all higher risk occupations. How do we diagnose melioidosis? Blood culture is gold standard. Where do we get? If we suspect systemic infection, they need to get from blood. Sputum, pus, urine, or throat swab can also be obtained for doing culture. We have to let the lab know if we suspect melioidosis so that they can keep the workers safe. Serology is of limited utility in endemic area if they already have some exposure previously and they may have positive background. Treatment. So empirical sepsis in the wet season need to consider melioidosis because if we are just using beta-lactam penicillin, that may be drug resistant. Intensive IV phases, we have to consider meropenem or ceftazidime, and for eradication phases, the long period of oral trimethoprim and sulfamethoxazole combination. Treatment itself would be outside of occupational scope, but we need to know in general sense. Hierarchical controls. As usual, can we eliminate soil or water contact in the wet season as possible? That's good if we can. What can we use? We can also consider mechanization of the tasks that would put people in such environment. Drones, for example. Engineering, if we can use enclosed caps in the earth-moving plants, we can chlorinate the bore water and using the wet suppression rather than high-pressure aerosolizing sprays. Administration, Similar to other infections, education and raising awareness about the risk factor and the infection features and personal hygiene that include wound washing, protection, and using the proper pre-placement screening before sending workers to the north end. Personal protective equipment, which is the last line of defense. We can consider waterproof boots, glove, eye protection during high-risk activity, the respiratory protection at with minimum of P2 for aerosol generating work activities, especially after post-cyclones. There is no specific vaccines available, but we may consider chemoprophylaxis for high-risk worker depending on the risks and their health conditions such as dialysis or type 2 diabetes. Well, that's all for melioidosis for me today. I hope you enjoy this brief summary.